are going to skip forward to the first symposium from an industrial radiotherapy company within the BGICC in its 7th birthday. So I'm so happy to have representatives from Elekta today, and we will start the symposium of Elekta by having the first lecture by Dr. Susan Springer, and she's the Global Medical Affairs in Elekta, and she's introducing brachytherapy, clinical outcome, ensure a promising future. Thank you. Please.
So thank you very much. And thank you to Professor Ghazali for inviting us to share our brachytherapy knowledge at this Congress. I'm Sue Springer. I'm the Global Medical Affairs Manager for Elekta, and I focus on breast and gynae brachytherapy. And what I want to do today is really to go over the recent data with brachytherapy in cervix, in endometrial, and in breast cancer. There's a lot of exciting data currently ongoing or just published, and I really want to share a lot of this with you today. So I'm going to talk about cervix, endometrial, and lastly breast. And the title of my presentation, A Promising Future, really indicates the promise data which has been presented at key presentations last year in breast cancer. So let's start with cervix cancer. So we know cervix cancer is a very impactful disease. The last Globocan 2012 data shows over 500,000 new cases of cervix cancer per year and over 250,000, so more than 250,000 deaths. In North Africa, it's less than 100,000, but worldwide, still a very impactful disease. And if we look at how this disease presents, it's quite interesting because still up to nearly half of patients still present with later stage disease. And in developing countries, this is even more. About 80% of patients present with later stage disease. So this means that brachytherapy treatment in locally advanced cervix cancer is still very relevant in cervix cancer treatment worldwide. Brachytherapy is standard of care as in chemoradiation therapy for 1B2 to 4A tumours. It's in guidelines globally, in the NCCN guidelines, FIGO guidelines, ASTRO guidelines, etc. So brachytherapy plays a key role. And we know this from really nice recent studies. There's been a SEER database study, you may have heard of it, the HAND study, presented and published in 2013. And this shows quite a concerning drop in the use of brachytherapy, given that it's standard of care in patients with locally advanced cancer. So why is this? Another paper published last year, this is from the National Cancer Database in over 7,000 patients in the United States, shows that with a decrease in brachytherapy, there's been an increased use instead of IMRT therapy. Now let's look at the effect of not using brachytherapy. The HAND-SEER database showed very nicely that brachytherapy, when it was used in patients, resulted in a 12% higher overall survival rate and a better core-specific survival rate than patients who didn't receive brachytherapy. So this really confirms that there is standard of care in these patients. And the National Cancer Database study last year published, which looked more specifically at IMRT, showed that when IMRT or SBRT was used instead of brachytherapy, again, there were worse survival outcomes in patients with locally advanced disease. So we know then that brachytherapy is associated with better outcomes in locally advanced disease. What about the way that brachytherapy is done? And what about comparing 2D imaging of brachytherapy versus 3Ds? Well, there's a lot of studies and hospital series in this, and there's a really nice study ongoing by Professor Putter's group in Vienna. So let's first look at 2D versus 3D. This is the PDR brachytherapy study done in France, the STIC trial, where they compared in patients who received chemoradiation 3D treatment versus 2D treatment. What was the difference in outcomes? And you see here at 2 years a significantly better local control rate and less toxicity in patients who receive 3D imaging. And this makes sense really. You get better overall tumour coverage and better sparing of the organs at risk, so less toxicity when 3D imaging is used. There's also been a single series study done in Aarhus. These were results in Aarhus in Denmark. Their Nokia technique here was using 2D. That was the historical technique. But they saw also when they switched to a 3D technique, they have much better outcomes in local control and overall survival. Now I want to go on to describe the Vienna experience, but before I do that, it's not only using 3D that improves outcomes, but also using advanced techniques, such as interstitial catheters. If we bring in interstitial catheters, this is a diagram from Vienna, you see the dotted lines are without interstitial catheters, and the solid lines are with. You have the 200% and the 100% isodose lines here. And you see if you bring in 3 catheters here, on the right-hand side, that typical pear shape really gets expanded out laterally. And if you imagine with a tumour extending to the parametrium, you can get much better dose coverage to that tumour with the introduction of interstitial needles. If you want to spare organs at risk as well, you can also manipulate and pull your isodose line away from the organs at risk by using interstitial needles. So in the Vienna experience, they historically looked at not using 3D IGAVT, and then they looked at the new technique of IGAVT in 3D imaging planning, and they also found that their results, their local control, cancer-specific survival, were much better when 3D IGAVT was used. So as a result of these studies so far, guidelines certainly do recommend that when you can use 3D imaging for brachytherapy, do so, be that CT, MRI based, because outcomes for patients are certainly better compared to 2D. And as has been presented here in another hall just now, the Gastro have also produced very detailed guidelines of how to do 3D contouring, how to use CT, MR for imaging, how to perform this 3D IGVAT quite successfully. But Vienna is still busy, and you've probably heard there's an ongoing large EMBRACE study with over 1,000 patients where they want to really confirm that this Gastro 3D image-guided adaptive brachytherapy has good outcomes for patients. So this study is ongoing. As we speak, the EMBRACE study group are meeting in Vienna at the moment. I was actually supposed to be here, but I thought it was really nice to come and speak to you about brachytherapy. But they're meeting, they're closing the trial, and hopefully they'll be publishing their efficacy data this year. 22 study centres in the EMBRACE study, and as I said, over 1,000 patients, 1,200 patients, efficacy study data expected this year. You may have noticed last year there has been one safety paper published from this study, and that's on severe vaginal toxicity, and it showed that with 3D image-guided adaptive brachytherapy, there was less severe vaginal toxicity in these patients. But we expect a lot more interesting data from the EMBRACE study. Now, the participants in the EMBRACE study had already been treating patients with 3D image-guided adaptive brachytherapy, and so there is a study, the RETRO-EMBRACE study, retrospectively looking at 600 of their patients who were treated with this method. And this data was presented for the first time at ASTRO last year. And this is the result. It shows very good local control, very good overall survival rates you can see across all stages of tumours at 3 years. So I think this is reflective of some of the good outcomes that we can then expect from the prospective EMBRACE study, which is ongoing. What they're also doing before I go on to finish about EMBRACE is they're thinking about an EMBRACE 2 study where they take the dose constraints that they learned for the organs at risk and the local control of the tumour from EMBRACE and take that on into a next study to really refine the treatment even more. So a lot of nice studies going on in cervix. So we know that brachytherapy is standard of care for cervix in locally advanced cancer. We know that 3D has better outcomes than 2D. Also, image-guided adaptive brachytherapy through the EMBRACE trial is showing very good results, and more are expected. So good news for brachytherapy in cervix cancer. So let's go on to talk about endometrial cancer then. I was at the International Gynecology Symposium in Melbourne last year, and they really describe endometrial cancer as going to be a tsunami in the future, with the risk factors of obesity, increased westernized lifestyle of a lot of developing countries, they really expect the incidence of this cancer to grow quite significantly. Brachytherapy has a good role as an adjuvant therapy in endometrial cancer, and there's some nice data and guidelines and recommendations which have recently been published. So I just want to remind you about the risk scores for endometrial cancer. These are described differently in some papers, but in low risk, there isn't too much of a role for radiotherapy because the risk of loco-regional recurrence isn't so high. In intermediate risk and higher risk, then radiotherapy plays more of a role. I think in radiotherapy there have been two key studies, the PORTEC-1 study and the GOG-99 study, looking at intermediate risk cancer patients, where they found that when radiotherapy was given in addition to surgery, these patients had similar overall survival, but they had a decrease in local regional recurrence. A decrease from 12 to 15% down to about 3 to 5%. Now in these studies, they found a high intermediate risk patient group who had a really significant decrease in vaginal local recurrence. These patients had 2 out of 3 risk factors. They were either older than 60 years, they had greater than 50% myometrial invasion, or they had a grade 3 tumour. And the reduction in local regional recurrence in these patients was from 23% to about 5%. This was with external beam radiotherapy. There were side effects associated with external beam radiotherapy, and if you think of doing nothing, a watch and wait technique, and waiting for the recurrence to occur, this is also associated with side effects. So from this, the PORTEC-2 study, which you may have heard of, stemmed because they thought, could we be, with vaginal brachytherapy, as effective as external beam radiotherapy, but perhaps with less side effects? So as you probably know, the design of the PORTEC-2 study was then to look at the high intermediate risk group and divide them into the external beam arm of 46 Gray versus 3 times 7 Gray for vaginal brachytherapy, and look at efficacy, side effects, and quality of life. And as you probably know, the results of the PORTEC-2 study were very good for this group. So they found equivalent efficacy between brachytherapy and external beam, but better side effects in terms of gastrointestinal side effects with brachytherapy versus external beam, and less impact on the bottom left, you see, on the activities of daily living. So vaginal brachytherapy was really associated with very good results in these patients. Last year, at the end of last year in Melbourne, Professor Krook spoke from Leiden of the Netherlands and her team. She's the principal investigator of the PORTEC studies. Also looked at secondary recurrences of cancer in the pelvis after radiotherapy, because there has been some concern there may be an increase in incidence. This, in the PORTEC-1 and PORTEC-2 at the bottom, has found not to be the case. So when radiotherapy is added as adjuvant treatment, there's no increase in secondary recurrence of cancers. The Leiden group are very busy in their studies in endometrial cancer, and they've come up with another nice paper looking at patient and clinician preference for vaginal brachytherapy after surgery. And they found some interesting results. The solid black line and the solid grey line are patients and radiation oncologists who have a very low threshold for recommending vaginal brachytherapy for their patients. Interestingly, gynecologic oncologists have a slightly higher threshold for recommending brachytherapy. They want to see a higher reduction in local regional recurrence. So interesting food for thought. So if we look at then the guidelines that have come out around endometrial cancer, last year ASTRO published guidelines for endometrial cancer indicating the high intermediate risk group who are suitable for vaginal brachytherapy, and saying because of the side effect profile, it's actually preferred against external beam radiotherapy. There's also been a very nice, it's actually in press, in Gynecologic Oncology, a really nice review by Dr. Bill Small from Chicago in the United States, who very nicely splits out the risk groups for endometrial cancer and gives you the recurrence rates if you were to just go down the watch and wait observation arm versus the arm with vaginal brachytherapy. So it can really be discussed with patients how they would benefit if vaginal brachytherapy was given. And you can see in the low intermediate groups, you can see the difference in the recurrence rates, and then you can have discussions with your patient to refer them to radiation oncology or to give vaginal brachytherapy. But I would highly recommend you look at this paper because it has a really nice overview of all the data around brachytherapy and endometrial cancer. It's a very nice paper. So in conclusion, for endometrial cancer, there's clear recommendations for the use of vaginal brachytherapy in intermediate and high-risk patients, and there's improved gastrointestinal effects and quality of life for patients who receive vaginal brachytherapy. And certainly there's an emphasis from studies with patients that it really should be discussed with patients as an option, and patients may have quite a low threshold for considering it as part of their treatment. Now finally, I'd like to go on to breast cancer, and then I'm done. So in breast cancer, brachytherapy has a very nice role in accelerated partial breast irradiation. So here we have the flow chart for early breast cancer. And you can see at the bottom in the pink that brachytherapy can play a role as part of accelerated partial breast irradiation or as a boost to external beam radiotherapy. Now, why accelerated partial breast irradiation in women compared to whole breast irradiation? Well, it's convenient and it could have benefits in, for example, elderly women, women with children who have a busy logistic working life, and also people who might live further away from the hospital. In France, Dr. Hanoun Levy has done a very nice study in the salvage setting, so when there's been a recurrence of tumour, to show that you can very successfully give interstitial APBI rather than a mastectomy, with very good efficacy and outcomes. Now, there's guidelines available for accelerated partial breast irradiation. Some of these are older than others. The ABS, the middle ones, the American Brachytherapy Society, are the most recent ones, published in 2013. The ASTRO guidelines, which are slightly more conservative, are slightly older guidelines. You can see the differences in age in the ASTRO guidelines. They say greater than 60 years old. And the ABS guidelines, given recent data, have incorporated DCIS patients into the suitable group. Sorry, I've gone. So what brachytherapy techniques then are available? Well, multicatheter interstitial brachytherapy is the longest standing technique with the most data and really can produce the most optimal dosimetry. In 2002, the Mammocyte intracavitary applicator came along, and then more recently there's the Savi strut-based applicator as well. I know Professor Areche has been at the Congress these 2 days and talked about IORT as well as an option for breast cancer patients. So what about the interstitial data? We have a very good randomized trial from Professor Polgar in Hungary showing equal efficacy to whole breast irradiation and better cosmesis when brachytherapy, interstitial brachytherapy APBI is done. And I want to talk in a little bit more detail about the bottom study. That's a registry recently presented last year with over 1,300 patients from the US of 5 centres with a long history of doing interstitial brachytherapy, the PROMISE registry, the pooled registry of multiple interstitial sites. So what about the Mammocyte data? The Mammocyte data is non-randomised, but there is a large registry, the ASBS Mammocyte registry, showing good efficacy and safety in these patients. You see in one of the studies, though, if you do have a skin distance of less than 7 millimetres, there can be not so good cosmesis in these patients. So this is the Mammocyte registry demonstrating up to 7 years good efficacy and good cosmesis and side effects. And the Savi data in the Savi registry is also not so long follow-up, but also showing good efficacy and side effects for accelerated partial breast irradiation. So I want to discuss a little bit the recent registry, the interstitial registry, the pooled registry of multicatheter interstitial sites. So this is looking at accelerated partial breast irradiation with multicatheter interstitial brachytherapy. It's at 5 centres in the United States who have very long experience with interstitial brachytherapy. It's one of the largest registries, and the data really do back up the randomised trials done by Professor Polgar in Hungary. It has a very diverse patient population, patients as young as 22 and up to the age of 89. It also has 6.5% of node-positive patients, so it's a very diverse patient population. There are also 300 described as ASTRO-unsuitable APBI patients in this registry, so it was interesting to see the outcomes of these patients. 77% of these 300 were under 50 years old, and there were some node-positive patients as well in the study. So what was the overall efficacy and outcomes? It was very good overall efficacy with 3.8% and 7.6% of local control at 5 and 10 years respectively. In the DCIS patient population, there were over 200 DCIS patients in the study, and they also had very good efficacy and side effects. And the efficacy and side effects in the ASTRO unsuitable group was also good with 6 and 7% 5 and 10 year local control rate. And interestingly, patients under 50 or over 50, or patients with or without positive nodes, there was no increased risk of local recurrence in these patient groups. Professor Chen from William Beaumont has presented these data at ASTRO just gone in San Francisco and showed these graphs of equivalence in under 50 years old and over 50, and no positive or no negative. So nice, interesting results, and more data to come from this registry. We've just submitted a no positive abstract to the American Brachy Society meeting next year. So conclusions then around breast, that multi-catheter brachytherapy is associated with good efficacy in cosmesis and equivalent outcomes to whole breast irradiation. And also the ASTRO unsuitable patients have very good efficacy and side effects according to the PROMISE registry. So it is likely, as guidelines, particularly the older ASTRO guidelines, get revised, that they'll take into account this new data and that more patients will be suitable for brachytherapy in the future. I'm going to carry on. So what I want to do is just guide you to a couple of papers. If you're interested in the interstitial brachytherapy technique, it's just been nicely published by Professor Tang in the Journal of Contemporary Brachytherapy on the technique from sort of top to bottom, a good guidance of the interstitial technique. And this is the outcome, good cosmetic outcomes, a slide borrowed by Professor Kuski from Arizona. He is also very keen on using this technique on ladies with augmented breasts, so ladies with breast implants. With external beam, you can sometimes get unwanted contracture in those implants, but he very nicely does the interstitial multicatheter technique on top of the implant and has very good outcomes. He's also written this up recently in the Journal of Contemporary Brachytherapy if anyone's interested to look at that technique. There's nice ongoing trials in APBI, so it's a field that's very much alive. The GACASTRO group in Europe have a trial which is closed with over 1,000 patients looking at interstitial APBI versus whole breast irradiation, hoping to publish this at ASTRO this year, so watch out, it could come out very soon, this data. And as you probably know, there's a NSA-B39 trial running in the United States comparing whole breast irradiation with APBI done by external beam, interstitial or Nanosite. Hopefully those data will come out next year too. So more data to come in this area. So in general then, there's a promising future for brachytherapy, certainly improved clinical outcomes shown in locally advanced cervix cancer and in 3D versus 2D. And we look forward to the EMBRACE data looking at 3D image-guided adaptive brachytherapy. In endometrial cancer, certainly vaginal brachytherapy in the intermediate, high intermediate risk population has a very important role, and there's nice guidance coming out from experts in the field to tell us when to use vaginal brachytherapy in these patients. And in early breast cancer, certainly the PROMISE data is backing up what we know about interstitial APBI and other brachytherapy APBI. And we'll have more information around this also in the future from the GACASTRO trials, for instance, coming up. So for me, yeah, the future is bright and promising for brachytherapy, and it's an exciting time with the trials ongoing. Thank you for your attention. I think we're going to hear about new radiotherapy techniques. Oh, sorry.
It's just a little comment. So,
yeah.
A few years ago, with the emergence of the new techniques of stereotactic body radiosurgery,
yeah.
it was thought that the brachytherapy is coming to its sunset. It's fading. It's going.
Yeah. Yeah.
So, Elekta is selling both. You have the stereotactic radiosurgery techniques, and I think Dr. Wilson will talk about it.
Yeah.
And you are promoting for the brachytherapy. It is still there. It is still on studies.
Yeah.
This is a message I want to emphasize at this moment, because many people right now.
Do you guys believe that you can do that on an analog system? Honestly, I don't think so. Unless you have a digital system that is updated, new, and that is something that we've been working on for 30 years, so 7 generations of new control systems, you can't do that. You can't really make sure that the MLC is moving at the position where you want it to be at the same time as those rates is changing. At the same time, the table may be changing 6D-wise without having a digital control system. So I see a lot of people in Egypt especially talking about doing RapidArc VMAT on analog platforms, and that is really scaring me more than anything else, because I know eventually that's going to lead to a problem. The second thing that we'd like to talk about is the MLC. So the MLC as a tool can be big, small, can be fast, slow, but at the end of the day, what really matters is that you have to have MLCs that you can trust where they're positioned at the time that you think they're positioned somewhere. So our MLC is actually an Elekta. Have been the fruit of a long work. They're 165 millimeters across the board, and they're actually, I believe, more efficient in an Egyptian or in the Middle East and all over the world, because they're as flexible as you want. They can be used for SRS, they can be used for SBRT, they can also be used for conventional treatments easily. This is a comparison in terms of transmission, because when we talk about the MLCs, it's important to remember that they're 3 times faster than the competition, but it's also important to remember our leads give the least transmission or secondary dose in the market. Our data points at less than 0.5%. The competition data points usually at 3% or more. What that means is that when I'm treating 2,000 MUs in a VMAT or RapidArc treatment, or 1,000 MUs, I'm doing about, if it's 3%, we're doing about 30 to 60 MUs, scattering them all over the place. That's really a recipe for disaster in the future. But when you're doing it with an agility MLC with Elekta, you're doing it in about 5 MUs secondary dose. And that's a comparison done in Salzburg, in Austria. You can see there that the BTV receives about the same dose as everywhere else with any type of machine, but we're saving quite a bit of secondary dose when you go to Elekta. And obviously the high dose rate mode, everybody does that. Nowadays you can go up to 2,200 MUs per minute if you're using 10 MV, but remember, you can only do that if you really have fast MLCs. You're going to want to do some imaging, obviously, whether it's 2D, 3D, or 4D, we still can do all of that. Let's just remember that one of the key things about cone beam CTs or 3D imaging when you start using them quite often is that they have to be fast. Otherwise, they're not saving me anything. I'm trying to do a 3D image is I want to locate that tumor and I want to treat it right away. Otherwise, if it's going to take me a minute or 2 minutes to take that cone beam CT, what's going to happen is the patient is going to move and it doesn't do me any good. So in that respect, we finish our cone beam CTs in about 30 seconds, reconstruction included. The cone beam CT that you see here is a new idea from Mannheim University. They're doing KV and MV together at the same time. That way they finish the cone beam CT in about 15 seconds, treat the patient, and move on to the next one. And that is really just great because we minimize the chances of patient moving. We minimize also the chances of the tumor internally moving. So with the 3D, we can also do intrafraction imaging. So this is something new that is coming up in the market. A lot of people are talking about it. Also with the 4D technique, when you, especially for those tumors that move a lot internally, we can do a 4D CT and we can see where that tumor is supposed to be at any given time, and then we can treat based on that. Now, what I wanted to also talk about when we're talking about the tools is that in modern day, we have a lot of tools that can allow us to see where the tumor is, which a lot of people are talking about. Next year, X company is going to come up with something that tracks the tumor live. It tracks the liver, or the CyberKnife does a great job because it tracks a liver or tracks the position of a lung. And that's really funny because we've been doing it for 5 years. We've been tracking those tumors. This is what I had a chance to show this to Dr. Khalid in Mannheim, and I think it was pretty impressive for both of us, actually. What we call it clarity. So basically, it's a very easy idea, very simple, but it's one that gives you the best of results. So before you treat a prostate, you locate that prostate with a cone beam CT or with a 2D image. Great. So now you've located it, but the prostate has a bad habit of moving in both a predictable way, but sometimes in unpredictable ways because of gas or whatever else is happening internally. So how can we actually make sure that during that treatment the prostate has not moved? We have something that we call the autoscan. So it's a probe sitting on top of the patient, and it's moving back and forth constantly, and the software is recognizing the edge. So this is basically what it looks like on your treatment for the therapists. They can see right here. Right there. So they can see that the tumor has moved, and then obviously if it moves more than a certain number of millimeters, these numbers here, 0.6, 1.6, and 0.8 millimeters, you as a doctor define the threshold, and then the LINAC will stop automatically. And I have to say, insist on this. There's no human feedback needed. Once the tumor gets out of that range, we will stop. This is really interesting for the Egyptian market because it doesn't really need a cone beam CT. It doesn't need anything more than, you can use it with an old LINAC. You can use it with any LINAC, as a matter of fact, to track your tumor's life. So do you really need to spend that many $1 million to have a system that tracks tumors? It really doesn't, because what it's tracking is fiducials. And what we're doing is we're tracking the edges of the tumor. Something else that we've been hearing a lot in the market, that Elekta doesn't do any gating. We've been late on that. As a matter of fact, we have quite a few tools for gating, but this is one. Let's concentrate on the lung side of things. This is one that shows our philosophy for gating is not to do it at the CT and then try to do the same thing at the machine. Basically, the doctor defines the level of air or volume of air in the patient's lungs. And then based on that, we define a threshold. So where is my threshold where the patient is being treated? And that's it. And once the patient breathes out, that will go back to this area, and then the LINAC will stop the beam. And this is, again, all automatic. There's this little great magic box that is getting the feedback back and forth from the LINAC and saying, okay, I need to stop now, I need to continue now. So quite interesting that people are saying we don't do any gating. We also do free breathing gating. So what is the idea is that you have this device on the ceiling. It's beaming on the patient. There's no radiation. It's actually just light beaming on the patient, and it's tracking the patient. I think this is something that could save a lot of lives in Egypt, and it's really not that expensive. Why? Because we have a tendency, and I see this in the market, a lot of therapists have a tendency to put the patient, they're busy, they're treating 100 patients per day, they don't have that much time to sit and to spend to position the patient to the millimeter, to the sub-centimeter level. And what happens then is you as a doctor spend a lot of time contouring, the physicist may spend a lot of time doing plans, but then at the end of the day, if the therapist doesn't take that time to position the patient correctly, that's not going to amount to anything. So the idea is that this system will remember the position of the patient, and until the therapist puts them there in that position, it will not let them treat. And then from then on, it will track the level of breathing. What's going to happen there is it's going to see the breathing pattern of the patient, and you define as a doctor if it's 2 millimeters, 5 millimeters, 1 centimeter. So, and the patient also could have the option to see what is going on internally. So they can see right there, this is where I need to breathe more, and I'm safe within this area or out of this area. And this is nothing other than 3D glasses that cost maybe $5. So nothing really fancy. So in that sense, this is almost a magic system, because first it tells me where my position, if my patient, it guarantees me that my patient is positioned correctly. An experience that I had seen with Dr. Khalid when we saw this lung treatment being done was that the patient was being positioned for a lung treatment, SBRT, and they were positioned correctly. So the system was telling us, well, they're positioned correctly. So we take a cone beam CT, we can see the lung is positioned correctly. We should treat it. But this system was not happy. It was not letting us treat. And we kept wondering. So they took a second cone beam CT. And what had happened is the patient was a little bit, their shoulder was a little bit rotated. So it was beaming on the shoulder, telling them, you shouldn't be treating this area. This patient is maybe internally, the cone beam CT is telling you, yes, the patient is positioned correctly, but they're actually a little bit rotated. So that was pretty impressive for me, included. So this is basically what it looks like. It's just another screen that is sitting in front of the therapist, but it's ensuring you, giving you the guarantee 100% that the patient is positioned correctly, and even more, that they will, if they breathe out of a certain, or they move during the treatment or something, you will know it. The system will stop it. So again, tools against techniques. Let's remember that a lot of these tools that are out there in the market, either they're missing the 3D or 4D imaging system, they're missing fast MLCs, they're missing quite a few things. And I have to insist, we do gating in 3 or 4 different ways. Free holding, free breathing, and then exception gating. And I'm not here to talk about products. I'm mostly trying to concentrate on the philosophy of the technique. So this is what why we're not talking product-wise. I'm more than happy to come to your center and do the same presentation and show you more the product. Now, all of this amounts to nothing if we don't have a planning system that gives us the correct plan, and I can be confident that what it's telling me is exactly what is happening in the patient. The gold standard is Monte Carlo. We all know that. And Monaco 5 has been a Monte Carlo system for 6-7 years now. To our knowledge, this has not been done by anybody else. So this basically should close that discussion before we even go ahead. But let's remember, I mean, if there's a lot of conversation going on out there about the planning systems and how each one is doing. But in my opinion, Monte Carlo is the best. So why should we even be discussing something else? We do not see yet anybody in Egypt. I mean, a lot of people are trying to do the chartless, paperless approach, but it hasn't worked yet. We envision that that's going to be in the next couple of years. Hopefully somebody is going to take that project and implement it. We do have a system where you can do that. So I'll run you through a few slides where you see for the same patient the chart, the imaging, the plans, all of the documents, everything in one place. So this is quite possible technically. It hasn't been done yet anywhere in Egypt, but it's going to happen soon. I have a confidence that there are a few good candidates trying to do that. Now there's also the next step in the world of radiotherapy. What do we do? Okay. All right. 5 more minutes. Okay, so there's a tendency, I was saying, that we can put the treatment planning system and the oncology information system in one. And this is what I'm trying to show you here, is that we took that first step, or second step even, where you can actually take a cone beam CT and you can see the dose that is being given, and it can compare the isodoses, and you can view the dose volume histogram from your office or from your home anytime you want. So without any further ado, let's go back to that patient that had that lung cancer, and what do we do with it? Do we treat it 2D, 3D, or do we try to take the next level, or the hyperfractionated 5x 12 Grays triple F treatment? So these are some of the cases that I gathered from here and there. So this is actually from Mannheim. You can see that they're positioning, and this is from the chart. They're positioning the patient at 12:29, and he's finished at 12:44. So 15 minutes, you've already delivered 12 Grays. This patient is only going to come to the cancer center 5 times, and these are the results 6 weeks after. the flattening drills are free. A lot of people are scared about that. A lot of people are saying, well, I need them to reduce the margin, and I don't know what's going to happen to the if I'm missing any disease out there. It's basically proven now. There are a lot of papers out there during the last Astro that have talked about it. I'm more than happy to share some with you. We've met a few of these people that have done this, and we plan to bring them to the next Congress so that they can talk about. This is actually not even the most, how do I say this, the most impressive one of those papers, but this is from the US, in Minneapolis. They took this patient, and how many isocenters do we count there? 7, 8? This is just great in one ARC treatment, VMAT treatment. So, a few of other cases, these are a couple of brain metastases being done in the same ARC in 16 grays, one session. A couple meds as well done with 22 grays. You can see the total treatment time is actually 19 minutes. Beam on time is 7 minutes. Dosimetry-wise, we're doing good. This is actually one of those SC head and neck that we hate to talk about. And then TBI is something that we discuss a lot in the region, and we have a solution where you can do it with VMAT, so very easy. Now, my last point actually is, or the one for last, is about education. We do sell a lot of equipment in the region, but what we're hoping to do more in the future is that people will start looking at the value of education. What does it take is actually for me to use that machine to do what I want to do with it. All of these techniques, I need some sites like Mannheim or Heidelberg or Leeds or one of those guys to take me through the steps. And we have courses in there that allow you to do that. So you'll go for 2 or 3 days. You'll go through a whole course. Not only get a training in the center, but you go there and you go through all the QA steps, which is a good patient for what is a good candidate, hands-on. And the beautiful thing in Germany is that you don't have to do this on fake patients or phantoms. You can do it on real patients. And then I promise this is the last point, is actually the next big thing in the world of radiation therapy. You may have probably heard about it, but the MR-Linac, which has been something that everybody has wanted to do for about 15, 20 years, is something that we're about done doing. The first prototype has been installed. The second one is going to MD Anderson any day now. And those are actually 1.5 Tesla MR machine images where you can see the internal tumor motion happening. So right now we can even see the soft tissue, and you can beam on that soft tissue based on the image. So the idea in 2 or 3 years, what we should be able to do is that we should be able to look at MR images. The planning system will get those images as the patient is being treated, replan the patient as the dose is being delivered. So this is the future. This is something that the consortium is working on right now, but it is something that is happening. And the proof is right there in front of you. This is actually in Holland, in Utrecht. They're the ones that worked with us on it, and they're the ones that helped us develop it. But there are quite a few research papers out there that I can share with you as well that are talking about this project, and we're more than happy to show it to you. There are a few prototypes, and there should be a third one actually. That paper there is talking about Sunnybrook Group and the Christie Hospital also working on the same project. So that being said, thanks for your attention, and if there are any questions, especially you, Dr. Khalid, shoot.
Thing to go for the stereotactic radiosurgery. Yeah. But in between the neurosurgeons as I'm having part of my ethical code is a neurosurgeon affiliation. So, would you recommend for more than 3 to go for the stereotactic radiosurgery LINAC, or you should prefer that for the sake of the brain, as Dr. Sanaa Sokhi told us earlier this morning, that those are patients for stereotactic radiosurgery, and gamma knife has a good role in this.
Yeah, that's actually a very good question, and it's not only a question; it's almost a philosophical question. Yes.
Ask me about it.
Yeah.
It's the everyday question for an oncologist.
Yeah.
Where should I go?
The way I see it is that we're seeing more and more oncologists, radiation oncologists, actually going towards using tools like the gamma knife and such, other than the other way. Companies are trying to encourage doctors to go that way. There are definitely tumors like the AVMs and others that you cannot and you should not treat on anything else than the gamma knife. A LINAC, as good as it gets, as good as the accuracy you think is never going to have that accuracy of a 1 millimeter that it can guarantee you that you're not touching an optical nerve or touching something else that you don't want to be touching. A good person that could answer this kind of question is somebody that using the gamma knife and the LINAC at the same time, and that's you. So, but that's where I stand is personally is I wouldn't. There are tumors that I wouldn't never put on the LINAC. Even I'm a very strong believer in ours. I still wouldn't do that. Anybody else ready to heat up the conversation? Thank you.
Good afternoon, ladies and gentlemen. My name is Arno Roth, working for Elekta, formerly known as a company Nucotron, and since 3.5 years taken over by Elekta. I work 30 years in brachytherapy, and I want to explain you a little bit of our techniques, how to use brachytherapy in your daily life. Yeah, this congress is more about chemistry. So drugs, but 3 ways: surgery, chemotherapy, and we more focusing on the radiotherapy way of solving the cancer tumors. Ionization radiation is as a way, if it is high energy enough, then it is possible to treat the DNA structure, or to kill the DNA structure in the cells. And that is the way we are using with brachytherapy, and therefore we want to explain a little bit more. The healthy cells can be recovered more easily, quickly than the tumor cells, and that's the way radioactive is quite efficient. The DNA cells will be, by radiation, will be damaged and cannot survive any longer. They cannot reproduce, and they will be either not reproduce itself and will be die at the end. So we do it in a very high dose, and therefore it's quite efficient. Because we are using a radioactive material by itself, it will became in a stable situation. And so every day the radioactive source became a little bit weaker and weaker. We call that a half-life. So when you have a 100% strong source, after a number of days or years or seconds, the source will be half of this energy. Typically, we are using in radiotherapy iridium or cobalt, and that has 74 or 5 years half-life. Dedicated sources in the brachytherapy is iridium, cobalt, cesium, iodine, and that is dedicated height. The height of the energy in the second column is more about the depth, how it can penetrate inside in the tissue, and the half-life, so how efficient and how long you can use this source. As well, you have to protect the area around because it is damaged all tissue, all human being, so it has to be protected with normally a number of lead or concrete. This is done already more than 100 years ago by Madame Curie. She found out that it was radium, put it on the skin, and can remove some tumor cells already. So in the time being, it is much more improved. Most people know external beam, where you have multiple beams on the body that goes to the healthy tissue as well to reach the tumor area, and after that, healthy tissue again. So it goes from outside to the inside. With brachytherapy, we bring the source inside and we treat from inside out. So therefore, we can give a much higher dose compared to external beam. Typically, for external beam, we can talk about 20 to 35 fractions that can you take to 6 to 8 weeks. With brachy, we can do it in 1 to 5 fractions to deliver the same kind of dose. On the right side, you have a couple of our machines. We can do iridium and cobalt as well. So we have different options and solutions for your institute. We can do it as a monotherapy with curative, palliative, so even to improve the life of the patients. When the tumor is growing and you cannot breathe any longer, then with palliative you can improve the quality of life. You can do it before, after the surgery to make even all possible left cells to kill it as in another go. You can do it with liquids, with brachytherapy to swallow something. We are more or less doing it with sauces. And in sauces we have permanent seeds for the prostate. We have an upper picture. They stay permanently in the prostate for the rest of your life. Or we do it with a remote afterloading system. That is more or less our business. That is do with an afterloader. I emphasize a little bit more deeper into that. This is typically a room layout where you have a concrete wall around the treatment area, where you protect all nurses, doctors, other personnel. Only the patients stay inside the room. Everything is programmed before, connected to the patient, to the applicators, and after that you close the door, patient is left, and then you press the start button, and all the program will be delivered. The whole treatment will be delivered in one go. This is typically the source. We have only one source in the machine, with possibilities to two. The capsule is less than 1 millimeter. I have to give some demonstrations, but 1 millimeter handing up here is not really makes sense. So it can to all small channels, tubes, needles inside the body. So we can have it all small curvatures, lumen in the body. So we can deliver that with a high dose up to 10 curie, what we'll see later on. This is typically how you deliver the activity. It stay there for a while, and it deliver its dose. Now it is one channel, but you have multiple channels normally to create a 3D volume. So you can draw a curvature around. It's a little bit difficult to see, but you can have a curvature around the dwell times, where the source is staying still inside the body, and then with different positions and channels, and all together you create a 3D volume what exactly covers the entire treatment, the tumor area. We have everything simplified in one single mechanical movement in one direction, we can deliver really precise the dose in this area. To do brachytherapy, you have three essential points. Is a good planning system to calculate exactly the strength of the source with all positions, to see the tumor area, and in a combination of those two. So you have to know the plan is based on the image of the patients with the applicators attached to it. An afterloader, of course, where you have the source inside and dedicated applicators for each body site. Our company Elekta produce different types of afterloaders. We can do the proven one with more than 10 years in the field, and then the latest one is a Flexitron with new techniques, also iridium and cobalt is possible for delivery inside. I want to show a little bit of the typically workflow with brachytherapy. You started as a reference physician to make the images that can be CT, MR, X-ray, mammography, ultrasound, whatever. You create the tumor area. After that, you make an appointment. You place the applicators inside the machine. Inside in the body. When it is really attached as close as possible to either in or close to the tumor area. That is typically the radio-oncologist or the physician. After that, it is essential that the applicator in combination, the patient in combination with the applicator get a real picture so that we can calculate and measure the exact distance. And that's quite important to know exactly how to deliver the dose. For that, we require a planning system that we can import those images, and we precisely can calculate where the dose and how much dose will be delivered. You can also calculate and given what kind of critical organs one to spare, not too much dose in the bladder or the rectum, etc. After that, when you, for example, when you move the patient to one bed to another one, then a verification image is required. Otherwise, you can directly continue with the dose delivery, where you have put the patient inside the treatment area. It could be operating theater. Each bit is shielded. Then all channels will be delivered in one go. Typically, it depends. The time depends. This is from a couple of minutes up to 10, 15 minutes. It depends on the amount of dose you want to deliver, and the weakness of the strength of the source. After that, of course, we will remove everything, and the patient can either go home. We have all different body sites defined. We can nearly do everything. Brachy means close, so not too large volumes is not really possible with brachytherapy. When we can dive a little bit more in the applicator parts, we have different techniques with the nasal holes, the cavitary, liminal, and I go a little bit deeper now in the different body sites. We have a couple of applicators, so I think with a big audience it is not so clear what to see. I want to invite you to go to our booth, just outside around the corner to the right, and we are happy to explain and feel all the details of the applicators we can have. Here you have a couple of cervix applicators. They are different in sizes and in diameters. We can deliver a lot of hospitals. They have their own idea, and many times we produce a dedicated applicator for that area. Otherwise, we have here the esophagus. We have the bronchus, esophagus with detailed specifications for that body area. skin, that is the Valencia or Leipzig applicator, Freiburg flap. So we can do it also intraoperative during the operation. Many times the Freiburg flap will be used and to give a quick calculation and give a boost, and later on you can finish the operation. As well, all different sides you can see, all deep in the body, pancreas, the neck, even the tongue. So a lot of knowledge is in our widely spread type of applicators. We have the most different type of applicators, and I think that is quite crucial how to perform brachytherapy quite correct. Interstitials, I have that as well on the booth. I think that also with my colleague Susan Springer was presenting this on the screen. This is also used for breast. For all people, for all men, they get at the end prostate cancer. So therefore, we have as well different solutions. This is for manual afterloading, remote afterloading, but you can deliver as well for permanent seats. We have different solutions for this. It's a little bit difficult to explain for all the audience, so again, please visit our booth. And to get a little bit more knowledge about brachytherapy, we have a really nice site that calls aboutbrachytherapy.com, and there is in different languages an explanation for professionals and for patients how to use and what is all about brachy, and more explanation from professionals. So please have a look. There's another site that is Abrachy Academy and .com, and that's another one. There's a lot of information in there. I have a short presentation.